So now that we're recording, so bipolar disorder in general, just like many things, are extremely cumbersome. They have a lot of information, this med, that med, toxicity, being able to just diagnose in general. Yeah, I don't think this is going to work. I'm so sorry. They're fighting with the dogs in the crate. We'll give it one more try. One more try. They go in timeout. My apologies. So come here. Come on, you guys, please. So what I did today is had you do a little bit more work on your own prior to the class. And I read, the responses, and not everything was due, I think, before class. I think I stretched some stuff out, but hopefully you'll have a good idea. That way I'll just be adding to it. So what I'm going to do is I'm going to share my screen with you so I can show you the agenda. And so our main focus is going to be on bipolar 1 and bipolar 2. I know that if you watched Katie Morton's video where she drew on the whiteboard, I don't know what it is about that. That to me is just, it helped me actually be able to, even though I know what bipolar disorder is, I work with those who have bipolar disorder. I understand what's going on. It made it much more clear. However, so I hope that video was helpful. It can get really confusing. So we're mainly sticking, like I said, to bipolar 1 and bipolar 2. And I will just mention right now, cyclic means just you're cycling really fast, just exactly what it means. But we're not, I say this, I think every class, we're not leaving psychiatrists, we're not leaving experts. I want you to be able to, on your test that you have to take, when you get, well, in my class, as well as when you go to take your state boards, is to have a better recall of things like, oh yeah, Amanda said something about lithium and toxicity. And I know that's kind of one that we're most known, but also there's another course of treatment for medication. And for bipolar disorder, just like schizophrenia, those are the two that medication, schizophrenia, 100%. Bipolar disorder, there are some, I like to be gray. So I'm just going to say it usually is needed. And one of the videos, I found this video, you guys, I was like, this lady, and they're both very short. She explains, I'm like, lithium so well. I'm so glad I found her. Hopefully, I can remember how to illegally I probably shouldn't say that on tape, but download it because sometimes they take them off. So, okay. So this is what our day is going to look like. So we're focusing mainly on bipolar 1 and 2. And then just a reminder, we do have a quiz at the end of class. It's going to start, it opens up. I've already made it open up. It's all on addiction. I gave you the study guide, exactly what to do. So if you did that, you should have absolutely no problem. It was very short. As you said, literally, I think I put like 10 questions. The only question I did not ask you was an extra credit question. I made it a little bit shorter than normal on purpose because it's pretty easy, or things we've gone over, and the study guide was very, very straightforward. So we will make sure to be done no later than 3:45. So you have a little space to go to the bathroom, get a snack, do whatever you need, whatever, just have it like a minute to breathe. So, and then it'll be open from 3:55 to 4:15. There's 11 questions. One of them, again, is extra credit. And then just to kind of go down here. So we're going to talk about, I'll ask you, some of these are questions, but oh my God, sorry, you guys, I apologize. Come here. Can you come here? She's okay. She has a little bit of brain damage. She has epilepsy. So she doesn't mean it. Right? You don't mean it. We're going to try. You said you were going to help me teach. Come up here. Okay. We're going to try. Nope, we're not. Okay. I think we are. Okay. We're going to try. So we're going to talk about, I wrote down some questions that I wanted to ask you because I feel like asking questions kind of helps to elaborate on things that might spark up in your minds and say, oh yeah, I had a question about this, as well as me verifying and going over things that we watch in the few videos. So today we're going to be watching 2 short videos. One is the one that I told you about already about lithium. It's like 5 minutes long. She is just pristine, in my personal opinion. The next video that we're going to watch is, do you guys know Nurse Mike? He's fun, young, right? He's adorable. I don't know. I think I am opening the chat, by the way, guys. Sorry, I forgot to do that. Love him. Yeah, right? He makes it so simplistic. And I mean, I used him all through nursing school, and he's getting even better now. And he has very good mnemonics and all of that. So I did use him as well because he helps to introduce the other 3 medications other than lithium. Because I think lithium, from my experience with teaching, we tend to think lithium, bipolar, that's it. But there are actually 1 of 2 courses. And again, it could be more medication on top of that. If somebody's very anxious, they could be on different medications, but we're talking strictly bipolar. So Nurse Mike's video is not that long. I chose a shorter one, but he talks about 2 of the 3 other medications, which I thought was really great, as well as we're nurses. So we need to know what to assess in order to know what to do. So for example, and I'll just bring this up right now. I was talking to, this actually just happened at the VA, so I want to share the story with you because I think stories help things stick. There was a patient, and when was this? Last Friday, I believe it was. Was it Friday? No, it must have been yesterday. Oh my God, that's sad. It was yesterday because I was with you guys last Friday. So yesterday, who kind of wasn't looking, it kind of looked a little off, if you will. And the first thing, because the student came to me and said, this patient is acting a little bit weird. They're really sweaty. They said they feel nauseous. And we went ahead and said, of course, blood pressure. One person did blood pressure and was assessing, and then the nurse came in, but I wanted to be a part of it with my students. So I said, what do you think the first thing we should do now that we know that they're safe, they're with someone and they're breathing fine, all of that was fine, but it could lead to something catastrophic. Let's go look at their meds. They were on lithium. So the first thing I thought of, they're showing signs of potential lithium toxicity. So what would we do? So you assess and then intervention and have that higher level of critical thinking. What am I going to do with this patient? Stat blood draw, right? Because I want to know what is the level that was happening. It was at a 1. And by the way, just so you guys know, on your assignments, if you saw me, I left, I think, 1 comment on someone's, I think they just mistyped it. Of course, it's going to be a little different at every facility, but normally, and I'll be very honest, I don't even know what your book says. Normally, from what I've seen pretty consistently, so I would never ask you the specifics, but it's 0.6 to 1.2. Now, if you put 0.5 to 1.2 or 1, that's fine because all hospitals are different. But I would never ask you on a quiz or a test the exact numbers because that wouldn't be fair, right? I mean, because they're going to be potentially just a little different. I would more focus on the symptomology and safety. So they had, I think it was like a 1.35. So, I mean, it's not good, but once you hit 1.5, that can be dead. I mean, that's really bad. You don't want to see that. That actually makes me anxious and nervous. And I know I seem high, I'm very high energy and all of that, but when I see that, that actually internally causes me anxiety because the patient could be at risk, right? So anyway, long story short, assessment is very important. Assessing, acting quickly, what medication are you on and how can I fix it? So it was at the VA, so he went to the emergency room, they pumped him full of fluids. And then, and I, of course, because it's me, I called and asked today how he was doing, and he's doing okay. Or they are doing okay. So, any questions about that before we move on? That's my story of the day. Sorry, my dog is seeing his own reflection in the window, and it's very intimidating. I may just have to put them away because it's distracting me, which we need to get through this. So they get one more try. All right. And I think we're losing. Okay. So, all right. So I'm going to ask someone, and if you do not know, just say next, and then I'll ask somebody else. Okay. we're in a safe place. This is not discriminatory. We're just trying to learn. So hold on, because I need to go down here. Everyone, he gets me through nursing school, right? He's so good. And he is Drew, did you say that Nurse Mike is a beefcake? He might be with the baby, but yes, he is a beefcake. I agree. Yeah, he's handsome and smart. What's better, right? Okay, so what'd you say? He's breaking up. What'd you guys say? Or what did he say?
I was just joking on.
He's entertaining to look at, watch, and learn from. So, I mean, what could be better than that, right? Chat. Drew, your mic is crackling. All right. But yes, I agree. I think he's great personally. And I like that he does sell stuff, but he does stuff for free as well, which I personally think is really great to help with the community of nursing. The more that we can get, the better, right? All right. So as far as what I mean by category, does bipolar fall under, is it substance use? Is it a psychotic disorder, anxiety? Because we know under anxiety, what would fall under there? PTSD, OCD, psychotic would be schizophrenia, substance use disorder would be like meth use disorder, alcohol use disorder. So Andy P, can you tell me what category bipolar disorder falls under? And if you don't know, you can say pass. This was my other strategy to see if people are really here. Andy, I know you're here.
Oh, hello?
Yay. Andy?
Yes.
So do you happen to know what category bipolar disorder falls under? If it's a substance use, psychotic anxiety, or mood disorder?
I'm gonna guess.
I know you know it. So really think about what you're treating. So imagine like a grid, if you will, and you have, all of these different things: psychotic disorder, substance use, anxiety, mood. Think bipolar. What happens with people that are bipolar? They tend to be.
Is it a mood?
You are absolutely correct. See, I knew you knew. So you are absolutely correct. So that is something that did I spell mood right? It looks weird. That is how you spell it, right? MOOD?
Yeah.
It looks weird.
I think it's maybe because you just capitalized it and didn't capitalize the other ones.
Who said that?
Devin.
Oh, Devin.
I'm like noticed every little thing when it comes to like typing. I'm so crazy like that.
And I don't, because you're 80. Oh, well, maybe not diagnosed, but yeah, we're in clinical. Yeah, it's hard. Between me, you, and Nicole, it's like, oh my God. So, okay, but you're absolutely right. That's probably why you're right. Why did I do that? Oh, substance use, of course, because that's my fave. But you were right, Andy. And thank you, Devin, for pointing that out. So that is something that I would consider important to know. And when I say that, what does that mean? Probably maybe write it down, because it might be something that could come up later, because it is important to know. I don't believe you need to know every single little thing. Like some of the other professors do at my other college, like you must know this is this disorder, this is this one. Another mood disorder, just to throw it out there, would be depressive, or depressive disorder is a mood disorder as well, which kind of makes sense, I think. So, okay, so bipolar, it falls under a mood disorder. We will talk about medications. Like I said, I have 2 videos. The lithium assessment is very important. So can anybody tell me, and I'm going to kind of throw this out as a free for all, Nicole S., you are not allowed to answer this question. And neither is Devin. Not because you did something wrong, but just the 2 of you cannot answer this question. But does anybody else know or want to answer the question? If you were like I kind of said earlier, looking at somebody that might be on lithium, what are we looking for? Obviously the blood draws. We do blood draws usually when you first start, and this is important to know as well. I don't know how I would ask it, but it would be important to know, especially when you first start the medication, because people go on all different doses, which I will not test you on. Your blood is drawn constantly because we don't know how your body's going to respond to it. And then it usually goes to about every 4 months, then every 6 months. And then once you're stable, if you will, what have you, then it's about usually every, twice, maybe 3 times a year, depending on if you're not feeling well. Because we want to make sure that you do, because remember, now this is extremely important. And I know that probably you all know this, but I'm going to say it. Lithium has a very small therapeutic range, 0.6 to 1.2. That's not very far. So you can go from being fine to not fine very quickly. And that can happen for a multitude of reasons. Usually that's why we say don't change your diet. The video talks about this a little bit, so I don't want to say too much. Sorry, I'm trying to make sure I keep on the chat as well. I'm here. Sorry. It's okay, Kenneth. We got you. I already told them you were going to be late and you're safe. And you're not in trouble. So, can anyone tell me if you were, let's say we put a patient on lithium a month ago and they are coming back for a checkup, what would be something we would look for in that patient or ask them? Or physically looking for specifically?
They might
I
have
would want to look for signs of toxicity.
Was that Hannah?
No, that was Katie.
Oh, sorry. Hannah lit up and then it was.
I think we both started talking at the same time.
You guys were like, you're on top. One Hannah's above you. So I'm like, wait, what? Exactly. So you'll look for definite signs of toxicity. Absolutely. And then Hannah, did you want to add anything?
I just was going off of kind of the toxicity. If they had tremors, like that would be an issue. And you'd be able to see them.
Absolutely. So both of those are absolutely correct. Other than, of course, asking how they're doing, which this wasn't what I was going for, but I'll mention it. How they're doing, how are they feeling? Looking at their labs, because by that time they should have probably had their labs done twice. I would take a look at it, see how they're feeling, if it's working, because it doesn't work for everybody. And you'll learn that also in that. Again, I picked very short videos because I know we need to be done at a certain time, but I also want to make sure that you have a really good foundation of this disorder, because it is, I don't want to say popular, but you'll probably run into a lot of patients no matter where you work that are diagnosed with bipolar disorder. So definitely toxicity. I mean, that is just a very, very dangerous. What are some symptoms? So now Hannah said something, I always call you Kroll. I don't know why, because that's just, am I saying your last name right?
Yeah, you are.
Okay. So I just call it, so I hope is that offensive or is that okay?
No, that's fine.
Does anybody other than people who have already spoken about anything today want to mention what would lithium toxicity look like before we watch the video? And this is important. This will definitely be on your final. What are some
Would
signs?
you have some confusion and some like excess urination, or like you'd have to use the bathroom a lot?
What's it called? Be a nurse, Kenneth.
Polyuria.
I know that's your voice. Yes, very good. So polyuria, that's one of them. One of them that's actually not mentioned as often, so I'm glad that you mentioned that. It could be potential polyuria, confusion. Excellent. Now somebody else, what else? Max said confusion as well. Sorry, impaired coordination. Yep. Muscle weakness. And what was that?
Blurred vision.
Yep, exactly. What else that doesn't feel good that we all hate doing? Comes out of your mouth. Vomiting, diaphoretic. Excellent. Okay. And that's why, and now if you think about all of this could look like a multitude of different signs and symptoms, right? That's why we always go back to what are they taking? What are they on? What's happening? So that we can hopefully get a better picture, because sometimes we have to act really, really quickly and we may not know. And if this person came in on a gurney and we don't know they're on lithium, that's why we do a full tox and we will find out. Sorry, my dog wants to be under the pillow and the keyboard. Okay, okay. Well, hello. Oh my God. Okay. So, all right. I think we're comfortable now. All right. Excellent, you guys. So these are important things. If I were to ask you a question, I'll just kind of give you a, and of course I'll make a study guide, but I'm going to focus more on the more prominent ones, diaphoretic, vomiting, nauseous, sweaty. You just don't feel right. You're confused. I've seen it. I don't want to say hundreds of times, so I mean at least 35 times over the years. We've been really good at the places that I work, but of course, patients take medications more than they're supposed to. You know, they'll fill in their little med cases, but we have to remember some patients are maybe a little bit, and not saying that we're not doing ageism, but sometimes if you're older, you have trouble putting them in, or if you're having not the best cognition because you're having a mental health crisis, you know, so we always want to be on our toes and think, what is wrong with this patient? Let's help them. And then if that does happen, they did overtake their meds, what are we going to do? We're going to either get social workers involved or make sure that somebody is potentially helping them so that they can take their medication correctly, because we want them to feel better. And also, and this is something important to remember too, on the other side, why else do we draw labs? Because we want to make sure they're at least a 1.2, because if they're not at a 1.2, we're not getting a therapeutic level, and then they're wasting, it's like a waste of, you're taking the medication for no reason, basically. So that's the whole kind of picture of that. Any questions about anything said so far? Very good job. Thank you guys for either reading or watching the videos or whatever you did. Thank you. All right, beautiful. Okay. He's happy now. Good boy. All right. So we did the assessment. We will watch the movie in just a moment about lithium specific. I'm not sure if I'm doing the movies I probably will do them back to back because they do go together, but I'm kind of feeling it out. We will do 3 NCLEX questions specifically to bipolar disorder. Are you guys familiar with ATI? They're kind of like a Kaplan, but they're parallel. So I took these questions. I wrote their NCLEX. They're not their ATI, but Mission uses, I don't know. I don't even know why I wrote it. It just seemed, oh, I know I did, because when I go over them with my students, when I give them their test, I want them, it's kind of a trick. So because I tell them to go over the questions, and so that if they don't, then they may get some wrong. But if you do what I'm telling you to do, I'm doing it for a good reason. That's why I did it. Oh, you little, you're lucky you peed on the pillow. Sorry, I just got my couch washed. Tyler, he's the only one. Sorry, my apologies. Should we give him one more chance, guys? Just one to be good. Violet's asleep. One more chance. Are you guys okay? I'm so sorry. I know it's a little distracting. I apologize. I'm trying to be a good mom. I haven't been home. We're okay with that? Okay. Oh, okay. Oh, well, now I can't. Okay. Lay down. Lay down. Okay. All right. 2:06. We're doing good. All right. So what I want to do here is, so we did the lithium assessment. You guys did great. And then what other medications can be used to treat bipolar disorder? So I do want to talk about this before we watch the videos. I am actually going to pause it really quick. My apologies. I'm going to put them away because it's distracting me and making them bark, and I want to give, it's gone too far. So if you guys can give me just one moment, I'm going to pause. I'm just going to mute myself. I'll be back in like a minute and a half. Okay. I appreciate it. Thank you. My apologies. Violet can stay out because she behaves when he's put away, and now I feel like a bad mother, but let's continue. So I think, no, I did not explain this to you guys yet. So, and this will also be in the video with Nurse Mike. usually when somebody is diagnosed with bipolar disorder, there's kind of one or two routes that are gone down. So lithium, I think, is the most familiar. So we either go down the lithium route to help with mood stabilization, helping with, suicidal thoughts and as well as preventing mania. And then we also have another kind of way. It's usually one or the other. However, I do want to say this. I have seen them do both together. I'm not going to test you on that. What I want you to remember is usually they go one or the other, but sometimes I will see lithium with one of the other three meds that I'm going to mention, and I will say it again at the end of this part. So the other way they go are actually 3 specific anticonvulsants. So does anyone happen to know? So there's 3 specific ones they use, and we're not actually quite sure why those work. Lithium, at first they didn't know why it works, but I finally found the perfect video. I'm like, I just want someone that explains it so well, and she has a very nice energy. Does anyone know any of the 3 other, they're anticonvulsants, and it's a specific 3. So it's not just any anticonvulsant.
Is it Depakote is one?
Absolutely. Very good. So Depakote is one of them. Alexa.
Lamictal, I think.
Yes. Very good. And there's one more. It starts with a T.
Hong said in the chat, Tegretol.
Did someone really? Oh my God, you guys are so smart. Yes. Excellent. That's exactly, wow. I think this is the first class that ever knew that. So yes, that's absolutely correct. So kind of, again, I don't like to be black and white because everything's gray. So I usually start off by saying we usually go one of 2 ways, either go the lithium route, and some people will say, no, I am scared of lithium. I've heard about the side effects. I can't eat more salt, or I shouldn't change my diet, or I have to drink this much water, or there's this whole thing around it. Because they usually will, or they should give some sort of like literature about lithium before you give it to a patient to take it home, just about their diet and not making huge changes. And the video talks a little bit about why, and it'll make more sense. And I think it's really interesting because I'll leave it at that. And then the other 3, so this is important: Depakote, Lamictal, and Tegretol. So those 3 specific medications, they're all classified as an anti-convulsant. We're not completely sure why they work for bipolar disorder, but we do, for whatever reason, because we don't know everything. I don't know how. My assumption is they tried it on somebody that was taking it for something else, and they're like, hey, their mood is much better. And that's usually how something's used off label, right? So, but I have seen actually more now lately, and I don't know if it's like some new fad that's going on, but I've been noticing, especially when, remember, different hospitals do different things, but specifically the VA, I've noticed that they've been doing more lithium along with one of those other 3. Because when I first started, it was one or the other. Now I've been noticing people are on and this is so I'm not going to test you on that. I'm giving you my critical thinking aspect because I want to know. I'm like, why? But I don't want to bother the nurses because, well, quite frankly, they probably don't know. Just being real. Not that they shouldn't. I would be asking the psychiatrist, please explain this to me. But sorry if you work at the VA. That was no pun, like nothing about you not knowing, but just from my experience. I'm going to find out though. But I'll notice they're on lithium and they'll, let's say Lamictal or one of the other 2, but at lower doses. So my thought process was, and because a student asked me, they're like, oh, I find, because I had to explain the 2 ways. They're like, but Miss Amanda, they're on Tegretol and they're on lithium. But I looked at the doses and I said, interesting. Let's think about this critically. Let's think about what we know. And we're making an assumption, but let's, utilize our intelligence of what we know about these medications. And they were both at lower doses, meaning what's going to happen usually if you use things at a lower dose? Usually you're going to notice less side effects. So I was like, oh my God, I wonder if they're trying to get fuller coverage However, do lower doses to get less side effects. So that, again, I'm not going to test you on that because that's my own theory. It's not, that's just my thought process, but I wanted to share that with you because as nurses, it's kind of cool to do that and really use, I mean, we can figure things out just knowing certain parts of what we know and being able to kind of put things together. And I know they do that for ADHD. So with stimulants, that's a new thing that they're doing, that they'll give a lower amount of, let's say, Ritalin, and then they'll add in like a potential habit forming, but at a lower dose, and then something like guanfacine, which is for blood pressure, which is used off label. And they both work on different parts of the brain, lower doses, but more coverage, and you have better results. So who knows, maybe that's why they're doing it. So any questions about lithium? And I go like this on purpose, but because if I test you, I'm going to test and say something like true or false. Lithium is the only medication that can be used for bipolar disorder to help with mood and mood stabilization. It would be what? False, right? Because we just learned that we can use Depakote, Lamictal, as well as Tegretol. So those would be more of the type of questions I would ask. And just you recognizing those medications, I think would be fantastic, because you might see Lamictal, and then usually in most hospitals, it will say prescribed for mood stabilization. And then you'll think, oh, I wonder if their diagnosis is bipolar. So then you'll look up and it might say, and Lamictal could be given for different things. It might say bipolar too, who knows? And then all the connections start. It's a beautiful thing when it starts happening. And hopefully it's already starting to happen, I hope. Okay. So we will be taking a break, don't worry. I just want to get through a couple of the activity type things. So let's go ahead and finish up medications, and then I'll move up the break. But before we do that, I just want to mention one more thing, and then because I've already mentioned it before, but one reason it's so difficult to diagnose bipolar disorder, the first question normally that a clinician will ask is it in your family? It's a very genetic disorder. And many people have it. And again, no stigma here. I'm hoping no stigma. I mean, that's what we're trying to do, right? Is lessen the stigma. But looking at the properties of the symptomology are so similar to so many different things. And I have mentioned this before, but I want to mention it again because it may come up later on, because you are one of the first people that sees the patient. So let's say you're working in a doctor's office or wherever, and you're doing an assessment of a patient, and you're asking questions, and you notice that they're pressured speech, they're talking really fast, and it could look like anxiety, potentially ADHD, or mania or hypomania, right? And that's kind of what I'm talking about down here. So it's about differentiating that, because you treat these all very, very differently with very different medications, if medication is the route that you go on, or not medication, because it could be done through a different route, or it's just such a huge importance to do your very best to get. I told you guys before our story, so I won't tell you it again, but yeah, I mean, if there was a wrong diagnosis, it happens. I mean, clinicians are not perfect, and we go off what we go off of, and sometimes we learn, which leads me to my next question before we go to our first video. And that is, why is it that we do not, or why is it considered a contraindication to give somebody who is bipolar something that includes touches serotonin, basically like a SSRI or an SNRI? Why is that a contraindication? Or contraindication, sorry.
Well, isn't bipolar disorder an imbalance of neurotransmitters?
It is.
One of which is serotonin.
Ooh, I can't wait. That was actually one reason why I like the video that you're going to watch next, because they talk about that. That is absolutely true. Did I not? I'm so sorry. I can't remember if I quizzed you guys on this yet, Maybe it was only the other school. So maybe we haven't talked about it, but so that is true. There is a specific reason if serotonin is, so for example, if let's say a patient came in and I was doing medication reconciliation and I saw their diagnosis was bipolar 1 or bipolar 2, it doesn't matter, bipolar. And I saw that they were on Zoloft, Prozac, something, Effexor, any of those medications, that would be a first red flag for me, because anything that has to do with serotonin can actually potentiate mania in somebody that's bipolar. So technically, an SSRI or an SNRI or any other medications that have to do with serotonin can potentially, usually it's those two. So just remember serotonin in general. That doesn't mean you have to run to the doctor right away and go, oh my God, they're on the and have like a complete freak out, but it's more of a concern. However, I have seen there are a very small, because remember, it's not black and white. Mental health is very gray. This happened yesterday. We were going through the chart because they were making a care map and we were looking at it and I said, interesting, what do you see that's interesting about this patient? And they didn't quite, the student was a little confused. I said, what's their diagnosis? They're bipolar 1. And I said, what medications are they on? They were on Zoloft and Wellbutrin, both which hit serotonin. However, they were both of those medications were on the lowest dose and they had been on it for weeks. So my thought process again was, oh, I wonder if they're trying something because they're not sure. And then guess what? We went down and it said rule out bipolar because they weren't sure. So the whole reason I'm explaining that is because it can be hard because sometimes we don't know what they have. Not that sounded rude, not they, but our patient population. So just keep in mind that in most cases, it would be a contraindication to give a medication that ignites serotonin to be left in the synaptic cleft longer if you do have bipolar disorder, due to the fact that it may cause mania. That doesn't mean it's black and white, no, but that question will probably come up on your final. Does anyone have any questions about that? Just, I think remembering it's important. My understanding is kind of like, now I feel weird calling you Coral. It sounds, and you're lit up on my screen. But mentioned about the, when we have serotonin and noradrenaline and dopamine, those are the main 3 having to do with bipolar disorder. And they are, the video will explain it. I'll let the video do the talking because she does a better job than I will. But any questions before we watch that? So just remembering that that's a contraindication. So if you do see it, it might be good to let the doctor know. And I do that all the time, or NP or whoever. Hey, I noticed that they're taking an SSRI, but they are diagnosed as bipolar and they're showing signs of mania. Because that's what we do, right? We report back because we assess usually first. So it's important that's like a key thing. Okay. So let's go ahead and watch one of the videos and then we'll take a break and then we'll come back and watch Beefcake and then move on. After that, pretty much it's almost done. We'll do a couple, the difference between, of course, mania and hypomania. And then just, you guys already did this in your homework, so we don't need to, go too much over it, but just to really differentiate the type 1 versus type 2. And if there's any questions about that. So any questions before we watch the lithium video? Okay. All right. Thank you. Let me stop the share and I will share. All right. And which one is it? It's this one. Okay, lay down. Did someone just sign off? I should make someone in charge, being like the hall monitor of the class. Okay. So you guys, can you all see that?
Yeah.
Okay. And it's the wrong one. Of course. I'm doing beefcake first, but I don't want beefcake first. I want lithium first, which is her. Thank you. Let me make sure the volume is all the way up and move this. Come on, work with me. There we go. Perfect. Can you guys see that?
Yeah.
Thank you. Okay, so Katie and Nicole, you're now on the top of my screen. Can you guys give me a thumbs up if you hear noise right now?
Lithium is
Okay,
the third
thank you.
element on the periodic table, but it's also so much more than that. Lithium and its compounds are used to make everything from cell phone batteries to airplane parts to pacemakers. And one compound, lithium carbonate, is also used in psychiatric medicine, most commonly to treat patients with bipolar disorder. If it's surprising that the same element used in batteries would be good for your brain, yes. But the stranger thing is, even though we've been using this treatment for decades, we're still learning exactly how and why it works. Doctors started using lithium compounds to treat neurological conditions way back in the mid-1800s. Then, in 1949, an Australian psychiatrist named John Cade discovered that lithium carbonate in particular could treat the extreme mood swings symptomatic of bipolar disorder. Over the next 70 years, this compound, which we'll just call lithium from now on, went on to become a first-line treatment. And now the World Health Organization considers it one of the world's most essential medicines. Having an effective drug treatment for bipolar disorder is great. Researchers estimate that around 45 million people worldwide have it. And while there are a few slightly different subtypes of bipolar disorder, it can cause someone's mood to fluctuate between depression and euphoric mania, or between depression and a slightly less extreme manic episode. All in all, though, this can be disruptive to everyday life. And on average, it can also shorten someone's life expectancy by 9 to 17 years. So having a drug like lithium is incredibly important. But unfortunately, it doesn't work for everyone. A 2017 study found that only 1/3 of patients can be treated effectively with lithium alone. For everyone else, it either doesn't work or has to be paired with another drug to get results. And for the longest time, we just didn't know why, or why lithium works, period. But finally, we've started to put the pieces together. For one, starting around the 1970s, research has gradually revealed that lithium can help stabilize magnesium levels in our bodies. Magnesium plays an important role in neurological health by helping electrical signals move from one neuron to another. And studies show that patients with bipolar disorder symptoms often have irregular levels of it. So the fact that lithium can stabilize magnesium levels means it could improve how signals are transmitted through the nervous system. But that doesn't seem to be the only way it works. Like the authors of a more recent 2018 study discovered that while lithium may play nice with magnesium, it gets competitive with sodium. Normally, sodium binds with certain types of G protein coupled receptors, or GPCRs, which are proteins found on cell membranes that help activate cell responses. Humans have more than 1,000 types of GPCRs, and they help regulate everything from our sense of taste to the levels of serotonin and dopamine in our brains. But in this 2018 study, scientists found that lithium can give sodium the boot. It turns out that when lithium binds with compatible GPCRs instead of sodium, it can deactivate them. But that can actually be a good thing. We're still learning a lot about how these receptors work, but we do know that they can be hyperactive in patients with bipolar disorder. And some GPCRs in our brain control levels of chemicals like serotonin and noradrenaline, which scientists believe are key players in bipolar disorder. So if lithium can inactivate some of these hyperactive receptors, that might be another reason it can treat symptoms so well. So overall, there are still some things to pin down, but we're finally starting to get a sense of why lithium works at all. And in 2017, another study came out that might even shed some light on why it only helps in some cases. In this paper, the researchers focused on mapping how lithium works on a molecular level. And in doing so, they discovered that bipolar disorder can be caused by a protein involved in nerve cell communication called CRMP2. In patients with bipolar disorder that didn't respond to lithium treatment, researchers found that CRMP2 was much more active than in patients who did respond to lithium. This matters for a couple of reasons. For one, by understanding how lithium interacts with these proteins, doctors could better predict which patients might respond well to lithium treatment. But also, these results could mean that bipolar disorder isn't always caused by changes to someone's genetic code. It could also be the result of how proteins like CRMP2 are treated inside cells. In the future, information like this could lead to the development of new drugs and even diagnostic tests. And since it takes the average person 8 years to get diagnosed with bipolar disorder, a diagnostic test could really speed things up. Of course, this wouldn't apply to all cases, and it wouldn't address other complications with diagnoses, like the stigma around bipolar disorder. But for some people, it would be a step in the right direction. Even though we've been studying lithium carbonate for decades, we've only finally begun to figure out some of its secrets. But the more we learn about this compound, the more we can understand how bipolar disorder works and how to develop effective treatments for those who need them. Thanks for watching this episode of SciShow Psych, and a huge shout out to the patrons on Patreon who make this show possible. Our patrons decided we should make SciShow Psych a few years ago.
Okay. So obviously someone talks faster than me. The reason that I showed you this, you do not please, I should have mentioned this before, all those compounds that she mentioned that I don't even know. I mean, I'm not going to make up that I do. The reason that I wanted you to see this video, because it's starting to show that, I mean, many medications, we don't know why they work. And it takes time. And that's just, I think, overall important. I'm not going to test you on that specific question. But also what Katie mentioned earlier about the serotonin and noradrenaline. Of course, there are and dopamine. There are neurotransmitters that are involved. The main reason is I believe she gives such a nice, very fast overall look at, wow, lithium. And that's why I think a lot of people might be a little bit nervous when they think about lithium and being put on lithium, is because it has that narrow therapeutic range. They go online, they look it up, and it's kind of scary. And it's like, oh my God, like she said, batteries, it's in batteries. And she mentioned something about salt. Do you guys remember that? She said something about, oh, lithium can take the place of sodium. And I promise you, I'm not going to get super specific on the medication in itself. I'm more curious, or more wanting you to be able to recognize toxicity, understand why we give lithium and what it's used for. That's my main thing. But also, just as a side note, has anyone ever heard someone talk about, oh, if you're on lithium, you have to watch your salt and water intake? Has anyone ever heard about that and want to talk a little bit about that? I know there's someone out there. There's a lot of you. There's 57 of you. Oh, look, you guys, we almost got everyone. So again, I don't want to get too deep into it because you guys have so much to learn already. Not that it's not important, but we give, again, always a sheet when we, most medications, but lithium, because of the very narrow therapeutic range, we have to be very careful. And we usually tell people, don't change up your diet just sporadically all of a sudden. Because what is lithium in general? It's a salt. So as you notice, it kicks salt out. So all of a sudden, if you're like, I'm going to start eating, for whatever reason, I'm just trying to, I don't know. You get cravings for salt. I don't want to talk about pregnancy because that's a whole different thing. And usually that's not my area, so I'm not going to go there. But with mental health meds and pregnancy, it's different as far as what medications can be taken. But if somebody decides all of a sudden, oh, I'm going to eat a ton of, or an increased amount of salt, especially if they're not drinking as much water and they switch to maybe, let's say, Diet Coke or coffee. What does coffee make you do? Pee. It's a diuretic, right? Doesn't that make sense? If lithium's kicking out salt and you're giving yourself more salt, that lithium's not going to work as well, and you're going to get a buildup of lithium in your system. So you're building up. Basically, the big thing to remember is if you increase your salt intake and or decrease the volume of water, because you know what follows water, or what follows sodium? Water. So water and sodium are very important as far as education for taking lithium. I do think that is very important for you to understand. So for example, if I was to ask the question, I'm just going to make one up on the spot here. You have a patient that came into your clinic today for a mental health assessment. They were put on lithium 8 months ago, have been tolerating the medication well, and now are complaining of, and I'll name some of the symptoms that we talked about, of toxicity. And one of the first things to ask is, have you changed anything in your diet? And they may say, oh, I've been craving a lot more, for whatever reason. Let's just say they got their menstrual cycle more, and they've been craving a lot more like salt and chocolate and like things that, cravings. That's what I'm thinking about. And I haven't been drinking as much water just because my water bottle broke. This is actually what happened to me, and I'm not drinking as much water, so I had to reorder one because it makes, I don't know about you, but it's like a pretty refrigerator. If my refrigerator looks pretty, it makes me want to eat the food more. So I put all the vegetables in front. I don't know. It's psychological, but it does work for me anyway. So it's kind of the same thing. And then I'll ask them that question, and right off the bat, I'm going to start thinking, okay, well, they look okay, but they're not feeling well. And I still want my patient to feel well. So I'm going to say to the whomever, let's run a screen for lithium. And they may come back at like a 1.25. Nothing, oh my God, dangerous. But then what does that give us the opportunity to be able to do to our patient? Teaching and or reinforcing teaching. And then be able to, okay, we need you to increase your, water intake, how much you're drinking now, explain the sodium balance or whatnot. Does that make sense? So basically my biggest thing is we want to not change too much with our diet. And that's usually one of my biggest, most simplistic things that I'll tell, especially with my teen patients, because they know everything. Quotes, they know everything. And so I'll just try to keep it short, but then I'll talk to their parents. So any questions about that before we take a break, and then we'll watch Beefcake? And who called him Beefcake?
It was Drew.
Oh, it was Drew. God, I love it. So we'll watch that because that has to do with the other medications. He only talks about 2 of them, of the anticonvulsants. He talks about lithium as well. And he leaves out, I think, Tegretol. He leaves out Lamictal. I don't know. He leaves out one, but I already told you what they are. So let's go ahead and take a short break. Let me just do some timing in my head, because I want to make sure that you have time for your quiz. And I hope no one's anxious about it, because it's, oh my God, seriously? Stop. Okay. So it's 2:35. Let's do what? 2:45? Sound good? All right. Go get some needed food, I'm sure. And I'll see you guys in 10 minutes. Recording. All right, here we go. I'll make it
to simplenursing.com. Click here to get started for free.
Can you hear Nicole? Okay, thank you.
Now for the bipolar medications. First on the list is carbamazepine. Indication is obviously bipolar, but also given for seizures. And a big one here is for treatment of trigeminal neuralgia, basically neuropathic pain. Now the side effect number 1 is leukopenia. We have low WBCs, which means increased risk or massive infection. So the key word here is to report fever and sore throat. Guys, that's the most important. Now, next is accidental pregnancy. So key words, oral contraceptives are ineffective, and we'll need alternative forms of birth control or birth control methods. Now, next is V for valpuric acid. So guys, just think Val with a lot of L's. So L for liver toxic. We monitor for jaundice and liver labs, ALTs and ASTs. And L for low platelets, AKA thrombocytopenia. We have a big bleed risk. Now, valpuric acid is also not pregnancy safe, and we teach clients.
Just as a side note, I think you guys know this one, valpuric acid is Depakote. The first one, which I'm not able to pronounce correctly, is Tegretol. So those are what he's talking about now. I am not going to quiz you on which one do you need to watch out for pregnancy or all of that. This is just extra information that is, it just shows that these medications, if you are going to mental health, you really do need to understand them, but I'm not going to quiz you on this. This is just a reinforcement of information.
hence not to discontinue abruptly.
Correct.
Now for the big mama, lithium. This is the drug to know. Coming up 22% of the time for all psychiatric med questions.
Yes.
So for lithium, it's given over the long-term treatment for both bipolar and schizoaffective disorder. So guys, the memory trick is a lithium battery, since lithium lasts a long time, and B for bipolar, remember battery. Now it has a very narrow therapeutic range, 0.6 to 1.2. And the key point here is that toxicity happens over 1.5. So patients at highest risk for toxicity are those with decreased renal function. Remember, kidneys are the washer machines of the body, washing the blood out from medications and waste. So any decrease in renal function usually sets the stage for toxicity. So be cautious with patients in kidney disease and also elderly patients who naturally have decreased kidney function. Again, the key signs for the kidneys are creatinine over 1.3 means bad kidney, and urine 30 mLs per hour or less means kidneys are in distress. And the signs and symptoms of tinnitus, ringing of the ears, usually indicates some type of kidney malfunction. So we use the acronym LIFT for all the key points that are highly tested. L for levels over 1.5 equals huge toxicity. So blood levels are drawn regularly to maintain that therapeutic dose and may take up to 3 weeks. So guys, a common test question, is lithium at a therapeutic level? If yes, then continue at the current dose. Now I is for increasing fluid and sodium. Since lithium lets go of the fluid. Guys, the big key point here and the contraindication is we can't give lithium during dehydration and low sodium, that hyponatremia below 135 microequivalents per liter. Guys, always question any prescription the doctor writes if the patient has low sodium or dehydration. Second thing is never restrict sodium and water. Keyword here, do not limit sodium intake. Since sodium swells the body with water, we need to.
My apologies. I said the sodium thing backwards. I'm sorry about that.
To avoid that toxicity here. Now, a typical question is a patient at highest risk for toxicity, usually a patient with a stomach flu, including diarrhea and vomiting. Now, the big key words here are due to massive dehydration. Again, always reviewing low sodium. If below 135, we're reporting to the doctor or HCP. And we teach patients to avoid the dehydration by teaching them to drink 1 to 3 liters of water per day and limit diuretics, including foods that have diuretic properties, like coffee, colas, and teas. Guys, we want more fluid in and less fluid out. So again here, no diuretics like furosemide or hydrochlorothiazide, and no anticholinergic medications like the respiratory med ipratropium because they dry you out. Again, we think PMs, you can't pee with them. Now our T is for toxic signs, when to report to the HCP. So guys, write these keywords down. Report excessive urination and extreme thirst. Guys, these both lead to dehydration and more toxicity. Now, vomiting and diarrhea, which can add more dehydration and again, more toxicity. And third, neuromuscular excitability like tremors and myoclonic jerks, or coarse hand tremors, and even ataxia, confusion, or agitation. Guys, the #1 intervention by the nurse is always to increase the fluids. Now, H is for hold the NSAIDs like ibuprofen and naproxen. Remember, NSAIDs are really bad for the entire body, especially the kidneys. So the key point, NSAIDs like ibuprofen, they decrease renal blood flow, increasing the risk for toxicity.
Yes.
So guys, we need to avoid those. And if the patient wants to take it, we need further teaching. So use acetaminophen like Tylenol instead. Now, common expected side effects that we don't need to report. Guys, the dry mouth and the thirst. So teach patients to use ice chips, gum, or sugarless candy, and drink plenty of fluids, and also do oral hygiene. Now, drowsiness and fatigue. Teach patients to avoid driving as well as hazardous activities until that improves. And we have weight gain. So we teach proper diet and exercise, and decreased appetite. If the patient has weight loss, it's anorexia and mild GI upset.
Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks to our team of experts helping us make these great videos. All right, guys, see you next time.
Hey, where are you, Beefcake?
Let us help you experience the.
He said something very important. I can't believe I forgot to put on my agenda. So, I would say every single nurse I've ever taught, whether licensed or not, which by the way, one of your, I always think it's important to say, just got a text message from one of your people. They just passed their NCLEX. So yay. So very exciting. So I don't ever think I've ever met a nurse that knew this. And I'll have people come in and they'll show me their medication. So remember, 2 contraindications. So this would be an excellent test question. Which of the following are potential, or, choose all that apply, or pick whatever that word we hate, select all that apply. Which of the following are considered a contraindication when taking lithium? A, naproxen, or ibuprofen, or Advil, or whichever one of those. That is absolutely true. I cannot believe I forgot to say that, because a lot of people do not know that. And a lot of physicians or whoever is like supposed to do the teaching does not mention it. Even though I do have a lot of patients that take it and they're just fine, why take the chance, right? Why take the chance? So it is a contraindication. What else is? Prozac would be. Is Tylenol? No. Is I could even be fun and add something in there on like lack of hydration. I don't know, even though that's not a medication, that would be a contraindication as well, right? So just understanding those things. So really the important things about making sure that we're hydrated. That's where I do most of my teaching, is hydration, and then avoiding NSAIDs, which I probably see about every 6 to maybe 15 weeks. Somebody will come in and I'll say, oh, that could potentially, even though their levels have been fine for years, but it could potentially, I'm still going to do the teaching regardless. So that's Nurse Mike. It's going to be on your video. It'll still be on this video. It's 2:58. I'm just making sure that we have enough time to not have you be late for your quiz. So I wanted to ask a couple questions here. So, or I'll just explain it actually. So we already talked about this. So the difference between hypomania and mania, I think everybody is very well versed in this, is that mania is at the very, very top. That is, it's potentially, well, it's pretty extremely bad judgment, very much having impulsivity, almost grandiose. I'm everything. They're getting a lot done. Everyone presents differently, of course. I'm just kind of naming all the symptoms. I had a friend actually, well, I guess she's still my friend, but she just moved out of the state. But she would, if she was babysitting my dogs, I'd come home and she was bipolar. And if she was in a hypomanic state even, which I didn't mind, because she would I would come home and she would be under my sink, like cleaning out, like putting everything in order. And I'm not making fun, but it's just kind of like cool, but because she was safe, she was hypomanic. And then, that will be my next explanation. So usually mania is when you're going to see someone hospitalized. If you've been in clinical, which I think everybody's been in clinical, you probably had some experience with somebody that's has mania, except for a few people in my group, because we know what happened when we were there. We were not allowed to go on 2 of the units because it was too unsafe. It happens, but if you do, it's very it can be very noticeable. And also thinking about the risk of hypersexuality and impulsive decisions, not using protection when you normally would, just again, not having clear thoughts, just your thoughts are racing, you're not eating usually. Again, this is not for everybody, but I'm just naming all the symptoms. And this will come in handy in one of our NCLEX questions that we're going to do after I explain now hypomania, which is basically just below that. However, usually people, this is where you're hospitalized, is mania. Of course, if somebody has severe depression and is suicidal and it gets into that, but more so than anything, it's usually during the manic phase because people are very dangerous. They're in harm to themselves and potentially others, you know, and I think that everything I mentioned would say why. Almost invincible, right? And spending money. We don't want to have someone end up in this horrible debt and then ruining potentially their family and all of that. So mania can be very dangerous. And then there's hypomania, which is a lesser version. And usually people are not hospitalized with hypomania unless they start to show, and by the time you're diagnosed, which hopefully, again, it can take years and years, you'll either know yourself or whoever you're around a lot will kind of notice that behavior and say, it's like the movie we watched, guys. Remember Call Me Crazy? When the lady started drag racing? You kind of, the daughter noticed immediately, like mom's not taking her meds or something like that. So I know we all know hypo is below. So hypomania is below mania. And quite frankly, a lot of people that are hypomanic, they like it. And hypomania and ADHD look so similar that that's, in my personal opinion, one of the hardest things to differentiate. And you don't want to be hypomanic for long periods of time. Per my psychiatrist and therapist, they say that it can cause toxins. I think I told you guys this, to go off in your brain if over long times of periods. I mean, it took about 2 years to finally say, no, she has ADHD. So, and I feel comfortable saying certain things, which I think it's quite obvious that I have a lot of energy. And non-medicated though, because I fit into the criteria where I feel I can function well. And if I can't, then I will not go to work or teach if I'm too much, if you will. So usually people kind of tend to get to know their own body. And that's why I think it's also so important on a therapeutic level and just on a real to real level talking to you guys is really listening to your patient and validating, like, and I say this to my patients, I don't care for even my psychotic patients, I'll say, you know your body best. Can you tell me what are you, and giving them that power, if you will. And even if they're psychotic and they're making no sense, doesn't mean that you have to treat them exactly what they're saying, but you're giving them that feeling of being a human freaking being, right? If you can imagine, like, that therapeutic relationship and trust and all, it's so important. Okay, so any questions between mania and hypomania? I know you watched the video, so I think you get it, and I'm pretty sure you do, but please, any questions?
I have a question about a patient we saw in our clinical.
Love it.
Not that many people, there's only like 5 of us that went to inpatient last week, but
Okay.
we saw a patient who I knew was manic, and she was really disorganized, thinking and saying different stuff, kind of wandering in and out. But the thing was, and I've personally seen this before too, but she just wasn't heightened. And I wanted to know if that's because of the medications that she was on are dulling it, or if that's like, because you wouldn't guess mania right off if you didn't know, maybe because she seems like so dull, but also really just kind of out there. Do you know what I mean?
I 100%, you could not have said that better. Of course, me not being there, I'm going to make an assumption, and really I don't have to, because I think you just really, what do they call it? Nailed it on the, or what is it called?
Hit the nail on the head.
Yes, I think you hit the nail on the head. So what, more than likely, without seeing what was going on, you mentioned the disorganization of thinking, which of course can go with other things, but you did see that the actual diagnosis was bipolar, correct?
Yeah, so I knew she was, but she was the main patient who was doing the most that I noticed too. So
I think you're absolutely, I'm so glad you brought this up, because I see this so often. Even my students, when we're in the, the throw of being in clinical, they'll ask, like, either or, depends on the patient. One week we'll go there and they're extremely manic, and then we'll go back the next week, they're like, what happened, what's going on? And it usually will have to do with either whatever medication they're giving. It could be a sedative to kind of calm them down while the other medication's kicking in. More
Mhm.
than likely, that's what happened. So they may have been giving Ativan just to kind of calm that person down until the lithium or one of the other 3 medications started to work. That is such a great question. Oh my God, I could talk so much about that because no, I mean, really, is Alexis, right? Yeah. It's a lot of people will present so differently than you would think they would present. I mean, I have some of my students ask me, they're like, why are they even here? And
Yeah.
when I say normal, I always do air quotes because what is normal, but they're like, they're so normal. And actually yesterday in the not in the ICU, in the at another clinical site that I was at, there was a nurse there, you know, and you would think, oh, it doesn't discriminate, right?
Right.
That doesn't completely, I kind of spun that off of your question, but that's an excellent question. So yes, people can present so differently, not just because of the diagnosis, but also because of the medication that they're being given to keep them safe. So they
Right.
were probably trying to keep him or her safe
Mhm.
until things got kind of at a better level. Oh, I'm so glad you asked that. Thank you. So do you guys see how like these interactions can really help us wrap our head around it? So please never hesitate to give examples or questions. It can be so helpful to and I like to hear what you guys are doing. Where are you at, Alexis? Good Sam or VMC?
Yeah, we're at Good Sam, and we just my like group just started going. So we
okay. Pooja?
We're with Pooja.
Oh, good. Okay.
Yeah, so that was the first time that I've like seen anyone in the inpatient, but I personally have seen I've gone to psych facilities before to visit people, and I've seen the same thing where there's a lot of people that are kind of creeping around and seem really odd, but they seem lowered. And I just like put that together finally, that's what it is, that they're just like medicated. So you see symptoms, but they're like not what you would think in the textbook they would be.
Oh, you just made my whole body, my heart sing. Because that's called making connections, right, guys?
Yeah.
We're making the connections between all of these things. And that's, I love that. And I'm sure many people are like, oh yeah. And as even now, 14 years later, I'm still, even when I get a connection, I'm just like, okay, that makes sense. Because the better I can be, I mean, I learn stuff all the time from you guys, my other students, my patients. So thank you. Excellent example. Beautiful. Okay. So now, before we watch, or no, we're done watching videos. Before we do our 3 NCLEX questions, the only thing I really wanted to kind of hit around where I think you guys understand, and because being able to differentiate between type 1 and type 2. So of course there's the DSM-5, right? And it's going to tell you and differentiate. But the basics of it is this, and I put it here and it's in the video if you guys want to take a screenshot, take a picture of it. Whatever you want to do, because this may come up and I will make it it's going to be simplistic. I'm not going to give you like 5 sentences of what they must have to be diagnosed. And I don't even remember all the complete diagnosis. I mean, I don't want to. That's why we have the book. I need to save room in my brain, right? But I think we all understand that type 1 and type 2. So, and I'll tell you how I remember it. If that doesn't work for you, you can think of your own way. That's absolutely, of course, fine. But what I want to show you is, I'm sorry, I have to show you this because we have a little extra time and it's like too cute not to show you. Do you guys see her in her chair on her purple violet pillow, like a queen? I'm sorry. Okay. Maxwell, did you like that if you're there? We know Maxwell likes dogs. Okay. She's so funny. I don't know who she thinks she is, but okay. So the difference, how I think of it between type 1 and type 2, because it took me forever in nursing school. I'm like, how in the, you must hit me this much. And I'm like, okay, I can't. And it confused the you-know-what out of me. So this is how I remember it. I first start by thinking type 1 and type 2 generalize. So type 1, I know is more mania. And I think more danger. So if something is number 1, usually doesn't that mean it's more danger? Level 1 trauma, right? So that's kind of how I think of it. So I have a couple steps to it. That's how I think about it. And then not saying that level 2 is like a walk in the park, but that's just how I differentiate. Level 2 is more depressive. Now, when you have type 1, you hit mania. When you have type 2, you do not hit mania. When you have type 1, you may hit depression, but you don't have to. And when you have type 2, you never hit mania, but more than likely you're going to hit hypomania. So what do I need you to remember out of that is that type 1 has more to do with you do hit mania, type 2, you do not hit mania. Type 2 has more to do with depressive, type 1 has to do more with mania. That's the key of really what I want you to get. You don't necessarily have to remember you must have for 4 days, this, and then for 7 days, this. No, that's not what I need you to remember. So type 1 is what? More, you will hit mania. So level 1 trauma, probably more potentially dangerous. Type 2, more depressive, and you will never hit mania. Any questions about that? I try to keep it simple so that it's like clear cut. So if you hear it, you can already kind of start thinking in your mind what you might observe rather than having, oh my God, how many days of this? And that's not what's important, in my opinion. And of course, if you want to do more research and if it interests you, that's totally fine. But for me, I think that's what's most important. And that's one reason why I wrote it out.
I have a question about type 1.
Of course.
So you have to at least hit 1 mania episode, but can it be like you go up to a mania episode and then you go down to like normal baseline and never below, and then you go back up? So it's only just normal and then mania?
You are correct. Yep. You may never hit a depressive episode in type 1. I almost said diabetes. In type 1, but bipolar type 1. Correct. You are correct. And I know the video of Katie Morton, it was a little confusing with all the drawings, but if you guys ever want, I personally, I love it. But I would stop after type 2 because then it gets really messy and confusing when she talks about the cyclic and the other 2 types that are newer. That's why I only stick with these 2 for now, because again, we're not leaving here psychiatrists. I would watch it just one more time. I think it's like that beginning part might be 5 minutes, just because even me still to this day I do, because it's just so helpful and it helps me remember. Because again, this is the hardest one for me. I don't know why. We all have our thing. This one's hard for me to teach. So hopefully I hope that you feel you're getting what you need. That's why I'm using a little bit more assistance with videos. I'm not too proud to admit what my strengths and my weaknesses are. So I'm just trying to prepare you for NCLEX the best that I can. And that's a great question. So let's see. So must hit mania for bipolar type 1. You may never hit depression. Oh yeah, it says it right there, my dear. Look, may never hit depression, may stay in the more baseline normal for you, whatever your baseline is. And then you need at least 1 episode of mania. Then type 2, you never hit mania. You might get hypomanic, but it's more depressive type hypomania, and must have 1 episode of depression. And the main way to diagnose is to know if you hit mania or not. And that's where they psychiatrists or whomever's diagnosing you is really, if you've hit mania, you know for sure, boom, type 1. If you have not hit full mania, and that can take some time, right? Like the woman said on the video, 8 years, my God, that's a long time to suffer, right? Or potentially not know what's going on, and like, why am I sad? And then why am I so happy? And then what is happening to me? And most people will think I'm depressed, but then all of a sudden you're full of energy and spending all this money. And it's like, yeah, so it can be a really difficult. And if anyone knows anyone bipolar, my mother was, It's a very, it can be difficult. I'm unmedicated and untreated. So it can be a very difficult thing to be around, which Katie, I almost said Katie Crawl. Oh my God. Katie Morton in the video talks about how it can be very, very difficult, because if you're at a baseline, even me having ADHD, being around someone that's manic makes me anxious. Not in like my work life, but my personal life, because it's very different.
Amanda?
Oh, that's me.
Yeah, this is Max. I actually have been living with someone who's bipolar,
Ooh, okay.
like kind of on and off, and
Yeah.
it is pretty intense sometimes. Like she's been super manic and has been spending thousands upon thousands of dollars that she doesn't have.
Oh.
And she doesn't really get to the, well, she actually does get to like depressive stages too, and it's kind of like random, and she'll just start crying. But generally she's just been like at a 10 out of 10 for like 3 weeks straight.
Number one, thank you for sharing. Again, these really help kind of bring things into perspective. And with mania in general, the DSM-5, unless I'm completely forgetting, it's 7 days usually mania that's like will last, but several people will get it for weeks. And it is, as Max just said, it's really difficult. And how, in my opinion, how sad you can potentially, I mean, ruin your credit, spending all your money. I mean, all of these impulsive actions, right? And it's all has to do with having like Katie said earlier, the dysregulation in brain chemicals. And it's hard to watch, right, Max? It's really hard to watch. And it's like saying, like, again, like to someone who's depressed, get off the couch, go run, you're fine. It's like, it's hard to reason with somebody who's having those sort of symptoms. You want to help, but it's such a hard thing to go through and be a part of. So I wish them the best, and hopefully, do you mind if I ask, are they medicated or?
No, she doesn't take any medications for it.
Okay. Okay.
She should though.
If you're, can I get my opinion? I think Max is okay with that. I agree. That would probably help a lot with that impulsivity and not being able to think clearly. And I mean, and again, look, let's make one more example before we do our NCLEX questions, and then I'll let you guys go to have some time before your quiz. Wouldn't that be like, let's say someone has a process addiction of shopping. And then I see that there's a question. Let's say someone has an addiction, a process addiction of shopping. And that could be something also hard to tell for differentiation of mental health is one of the hardest things to diagnose, in my opinion. I think, again, that's why I love it so much. It's like a puzzle, and I validate people's feelings about how difficult it is. And I don't know. It's just, I think you love it or you just don't. I don't know. That's my personal opinion, but that could be something too, right? Because somebody could have bipolar disorder and their impulsivity of just buying a bunch of stuff and, you know, having people over all the time or whatever it may be. But like right now, I'm going to admit something. I didn't even remember. So you know how some people, like, what do they call it? Drunk. Well, they drunk dial. Or like when you're drinking too much and then you buy too much online. I sleep shop. So I do the opposite. I was like, I guess I ordered like 8 pairs of scrubs. So I remember it now, but I was like, okay. So that kind of doesn't have to do exactly what Max was saying, but I just thought that was an interesting that he mentioned that. And then, but that could be harmful too, right? Maybe I need to like disable my computer before I go to sleep, because I'll just wake up bored and be like, I can't sleep. I'm gonna shop. So thank you for sharing that, Max. Did you see the picture of my dog or the thing of my dog? I did it for you.
Yeah, I saw it.
Okay. You didn't seem excited though.
Oh, I was. My dog is here too, and he heard them barking, so he got up and started barking too earlier.
Oh God, these dogs nowadays, I'm telling you, they won't shut up. I don't know if it's the weather or what. I have something here. Is it typical of someone with bipolar disorder to buy the same type of thing when they are spending a lot. Not necessarily, I would say no. Now, could that be different for certain people? Potentially, but it's actually a very good question. It's more of the impulsivity of like, I want to, all of a sudden, oh, I want to buy clothes. I want to redo the house. I want to buy new lamps. And I think I might need a new car. It depends, obviously, how much money we have, right? Violeta, she sees the dog walking by. Sorry. She's so funny. She's like this big and thinks that she can like take on like years. Okay. Now she's jumping on the blinds. So I would say no. But of course, we're all different. So it could potentially be somebody who really loves clothes and that's just their thing that they buy. But so I would say it depends, which I hate giving that answer, but very good question, Kylie. Any other questions before we do the 3 NCLEX questions? And then you guys will have a break and you'll have your quiz open up. All right. So let me just share my screen with you. Which I think I might. Can you guys see this right here? Like the agenda?
No, we can't.
Okay, no problem. Because the agenda is on. Oh, that's why. Okay, share screen. It's on the same page. I tried to make things as easy as possible. Okay, can you see it now? It's black and it says.
Yeah, I can see it. It's just a little zoomed in. So it's cutting off the left side.
Okay, how is that better?
There, we can see the full thing now.
Okay. Perfect.
Yeah, it's good.
Awesome. All right. So let's go ahead and does anyone want to be brave and take on question 1 and explain to us why they picked that answer? It's a select all that apply, but it's not super scary. I left one of them out because I was like, I'm not even going to put that in. Anybody? Sure.
I'm down to give it a try.
Oh,
Right.
sorry, you go, Kenneth.
Well,
for sure.
now we have 2 people. So, okay. Kenneth, do the first one. And then it was John or Drew. I think that was a voice.
It was John. I'll
John.
do the second one, I guess.
Okay, perfect. All right.
Do you want me to
away.
read it? Or
Okay, you've been in my clinical, bro. You know how to do this. You're gonna teach it.
it's been a while. Okay. A nurse is planning for a client who has bipolar disorder and is experiencing a manic episode. Which of the following interventions should the nurse include in the plan of care? Select all that apply. Ooh, so
what
for
are we
me,
looking for now? What are we looking for in the question? What are some keywords? And then we read the answers and explain why each one, why it might be right. So we'll keep it, or why it's definitely wrong. So I'm probably going to eliminate it. So what
Okay.
is the question?
So in the question, we can immediately see that the patient has bipolar disorder, which
Yep.
is really key. They're currently experiencing a manic episode.
Very important.
So it's most likely that they're not going to sit still. Their mind is just racing everywhere.
Very good.
They probably won't listen to reason.
Yeah.
Like as efficiently as a normal person would, quote unquote normal.
Mhm.
I don't think there's anything else in the question that's like super significant, but those are the 2 pieces of key information.
Except for the questions asking you. Read the very
Oh
end.
yeah. What interventions should the nurse include in the plan of care? Sure. I think A is definitely included because, like I said earlier, the patient is probably not really open to listening to like long spurts of reason. So I'm pretty sure like if you were to give them really small bits of explanations, that would probably be more effective than
Excellent.
trying to just reason with them.
Yep.
B is also correct in my opinion, because you don't want them to like spend their entire life savings, right? And you want to be consistent with them, because like what if you're just like, oh no, you can't spend this, and then all of a sudden you're like, oh yeah, go ahead. They're gonna be like, what the heck? And they're just gonna be like, oh, now these limits aren't valid anymore, and so they're just gonna spend and disregard what you have to say.
You are correct.
That is my thought process, at least.
You're
C,
right.
I don't think is right, and then D, I also don't think is right either, because I'm not sure if it's relevant. So as of right now, I think it's A and B.
You almost got them all, and very good, very articulate, very well spoken and very well said. So yes, definitely A is correct, concise, short. It's like, again, if you just had surgery and I'm going to explain how to take care of yourself at home, we don't do that. They're out of it, right? So it wouldn't make sense. So like you said, with the brain and not being able to take in potentially all of the information, let's keep things short. So hopefully we can get to where we need to be. So definitely select all that apply. We'll pick A. B, offer consistent limits, because we definitely want to be consistent with this disorder. There's several disorders, but with this disorder, borderline as well, which we'll learn about if you don't know what it's about. They love me, because I'll tell you why later, especially if you're very nice and smiley. They tend to push boundaries. So we want to hold boundaries with bipolar disorder. So definitely offering consistent limits. We, of course, don't want to disregard any client concerns. That's just not therapeutic, and we don't do that. Now, the only one that you did not get, and I'll explain why. So letter D is offering finger foods for the patient as an option. So the reason, actually, can someone else other than John, because he's going to give the next question, or Kenneth, because he did such a good job. And again, this is why we do this, right? Because we learn. Want to explain why offering finger foods might be important for someone who's manic. Remember, we have to remember the question manic. So they're on the go.
Do you think I could give it a try?
Of course you can.
Yeah. So is it just because like they're really fidgety, and I feel like finger foods would be like a really kind of like a distraction, but it's not too engaging because they're just eating, and like it's really like somatically stimulating.
I will take that answer as yes, and I'm going to give another answer so you can see it two ways. So that's not wrong. Very good job. So offering finger foods to somebody that is manic specifically, they're on the go, go, go. They don't want to eat. They don't want to sit down. So offering finger foods, chicken nuggets or something easy to walk around and be able to eat, is going to make sure they're still getting nutritionally, the nutrition that they need, but not forcing them to try to sit down, because that could cause escalation. So when you hear bipolar, mania in general and finger foods, I had a question like that on the NCLEX, just as an FYI. I actually added this. This was not on there. I switched it out for another question because I wanted you guys to know, because I had it on my NCLEX. So when you hear manic and food fingers, oh my God. Don't eat your hands, but finger foods, that could potentially be an answer. And that is why. Very good. Excellent job. Thank you, Kenneth.
I want to make a comparison for this answer option that I don't mean to be offensive at all, but for me, it made me think like the reason we give a lot of little kids finger food is because they're up and moving and don't want to sit and things like that.
Yes.
So it's like the same kind of reasoning.
Yes.
Right?
That's fine.
Okay.
Yeah, absolutely. No, that's, and that's why I always say, just how you just said, not to be offensive. No, that's absolutely an excellent comparison of why we do things. So no, and please, you guys, I can't think of everything in the world. So your help is probably going to help other people to, maybe what I said didn't make complete sense, but something else you compare it with will. So please give me everything you got. Very well said. Excellent. Any questions before John takes over number 2? I think it was, John. All right, John, it's on you. This is a hard question.
All right. So, question number 2. Nurse is caring for a client who has bipolar disorder. Which of the following is the priority nursing action? So we have A, set no limits for expected client behavior. B, administer prescribed medications as scheduled. C, provide the client with step-by-step instructions during hygiene activities. And finally, D, monitor the client for escalating behavior. So for me personally, reading through these answers, one of the ones that already just screams no is A, at least, only because setting no limits for expected client behavior, that doesn't really make any sense, because they're just almost letting them run free for all. So kind of letting them run at their own risk.
Correct.
For B, administer prescribed medications as scheduled. That one I'm not sure about because I know, especially with bipolar, if the patient is on medication, that we would want to make sure that we're following the medication regime set by the doctor. So that's a possibility, but I'm not sure right now.
Like the way you're doing it. Yep.
C, providing the client with step-by-step instructions during hygiene activities. That doesn't necessarily mean anything because if they're having bipolar disorder, they may not even be having a manic episode. They might completely be normal. So there's no reason to provide step-by-step instructions.
Because it doesn't say they're manic. Exactly. So do you see what he just did? So John just didn't make up a story. He's not making up a story. It just says bipolar. So excellent.
And then finally, the last one, monitor the client for escalating behavior. So this one I'm inclined to select because going back to B now, administering prescribed medications, it doesn't say what the medications are that we are prescribing. It could be anything. It could simply be an antibiotic or something else. So I'm inclined to say D because if they have bipolar disorder, we would want to monitor if they're going to become manic or if they're going to enter a depressive state.
Okay, so I'm gonna say you're a genius. I did not think that whoever answered this was a hard question. When I was reading it, I had to read it a couple times, and I'm like, okay, really think about this. So you are correct, and because I was like, well, administer prescription medications as scheduled, and this came straight from an ATI book. I think again, you guys are familiar with ATI as we had mentioned earlier, and I like Kaplan questions so much better, but it didn't quite make sense, but the rationale, which I think is the most important part, and that's actually, they showed evidence-based practice that's how we pass our NCLEX, is having the rationale. So I want to give that to you. So is because no matter if, like what you said, if they're depressive state, if they're manic, bipolar disorder in general can, if you guys read about it, well, I'm sure you did because I trust you read about it. And in one of the videos, it talked, or was that what I read? Oh, it doesn't matter. Bipolar disorder can switch back and forth. Usually it doesn't go back and forth super quick, but irritability, we don't know. We have no idea what could potentially happen. So what is the NCLEX all about? Safety, right? The NCLEX overall is seeing if you are going to be a safe nurse. So if all else fails, other than if you can only do one thing, which I love, some people don't, I do. Or you're like, I'm not sure, think safety. Would monitor the client for escalating behavior and bipolar go together? Absolutely. Because many people who have bipolar disorder can be potentially, and what does it say right here? It says priority nursing action. So it would be between B and D would be having to do with safety. Yes, I completely understand why B, it's like, well, if they had their medication, then they would be potentially more safe. But regardless of that, we don't know because maybe we're giving a medication that doesn't work or an antibiotic because it's not specific. So letter D is the, we call it the credited answer. So looking for escalating behavior. Any questions for John about that? It's a hard question. That's why I tried to pick questions that were kind of, really get you thinking about things. Very good. I'm impressed. You guys are, I don't know who you guys are, but I tell Colleen all the time, I'm like, these people are smart. Where did you find them? Excellent. Everyone's good? All right. Good job, John. And even good job, even if you got it wrong, it's still a good job because you're thinking through it. That's how you learn. Does anyone want to take on number 3? It's kind of an interesting one, I think.
I can try.
Please.
So it says a nurse is caring for a client who has bipolar disorder. The client states, I'm very rich and I feel I must give my money to you. Which of the following responses should the nurse make? A says, why do you feel the need to give money away? B says, I'm here to provide care and cannot accept this from you. C says, I can request that your case manager discuss appropriate charity options with you. And D says, you should know that giving away money is inappropriate. So for A, it is an open-ended question, which we always like, but I don't know if this is necessary in the situation, but I'm not going to throw it out right away. For B, when it says I'm here to provide care and cannot accept this money from you, it does a good job of shutting down behavior, which I think is good, and reestablishing your role as the nurse and their role as the client, and not having that like very personal relationship. So I do like that one.
Good.
For C, the one about discussing with the case manager appropriate charity options, that's perpetuating the behavior.
Excellent.
So I wouldn't choose that. It's feeding into it.
Yes.
And then for D, you should know that giving away money is inappropriate. That's not necessarily true. I mean, it's nice to give to charities and things like that. It's a little judgy and rude in my opinion. So I don't think I would say that either. So between A and B, I think I would choose B.
And you are 100% correct and very well explained. And I'll tell you why number one's not right. And you are correct. It is open-ended, and a lot of students like A, but it says why. So we try our best to avoid why questions. So that's just another little, and I'm sure you guys already know that trick. If you're like, oh, I don't know which one it is, more than likely nothing's 100%, but we try to avoid why questions. But very well explained. Number 3 was beautiful. I was gonna say I wish I had it recorded, but I do. So exactly, we don't want to continue with the behavior. And again, if somebody's in that state, we don't want to encourage them to give their money away, because maybe they don't really have as much money because they're grandiose, or who knows, right? And then they could lose a bunch of money. And here you're exactly right. You're not being rude. You're being therapeutic. You're setting limits. And we all know that we're not allowed to accept money from patients. And if you don't know that, do not, please, unless you're a clinician and you're taking money because they owe you money for being their clinician. But that was very well explained. Does anybody have any questions for myself or Katie about this question? Very good. So as always, guys, Kenneth, John, and Katie, you did an excellent job at, I don't know if you guys can tell, but do you notice that you're getting better at explaining things, the wording you're using, just how you're kind of, do you notice that? Or even if you're not talking, just you processing it, I feel like I'm seeing elevation in the higher level of thinking, which is excellent, especially at this part of the semester. So I'm very happy to see that. So as always, remember, NCLEX questions, and I'll put this on your study guide, are important, not because I'm trying to be nice and I want you to get it right, but to reinforce the thinking about it and whatnot. So these are important, and they'll be listed somewhere at some point, I'm sure. Or do I have these listed? No. So I need to, I'm going to list them, and then I'm going to do, what am I doing? I already, Andy and Fra, I'm probably saying the last name wrong. What am I doing after this?
Oh, sending out an announcement about attendance.
Oh, thank you. I'm like, Chelsea, that's it. I was like, I know the last name, but okay, perfect. So that is what I had planned for today. We are perfect. We're a tiny bit early. I can go ahead and open the quiz now when I get off of here, if you'd like me to, with that, or you'll have till 4:15 regardless, so it wouldn't matter. But is anyone like completely opposed to that? Or, I mean, I doesn't bother me to open it. Yeah, okay.
It sounds lovely.
Okay, so I'll open it. It give me like 3 minutes because I have to like sign in and then change the time. But you'll have still till 4:15. Very impressed with. It shows me that you guys are like doing the work and reading, and I really appreciate it. I know you have so much going on, and mental health may not be your thing, but I appreciate just that you're doing very well in this class. So thank you, and I'll post these questions so you have them, as well as I'll do my announcement. But before I do that, I will change the time on the quiz to as soon as I get on there, which will be like probably 3:45. So go pee or wash your hands or do whatever it is that you do. Any questions or anything before I see you guys next week? No? Okay. Well, you're fabulous.
Oh, I have a question.
Yes.
How was your date last week?
Oh my God. I was wondering if someone was going to ask. It was fabulous. He'll be here. We have a picnic on the balcony at 7. So.
Oh, I hope you have fun.
Thank you. I think it will be fun. I have a nice little setup out there. So, and the weather's like nice and I have a little heater. So it should be a nice time. He's a nice, I say kid. He's young, but oh God, I'm so recording.
How young?
He's 11 years younger than I am.
Robin the Cradle. Nice.
I mean, he's a nurse. And he's just so nice. Like the last thing I'll say, so I don't keep you, but this is mental health, I think, as well. As I think, people are brought into your life for a reason, a season, or whatever they say. But for certain people, it's like shows you how you deserve to be treated, whether it lasts or not. Then you really realize how you as a person deserve to be treated because maybe you've not been treated this well before. So that's my gem of the day for you guys. Drew, right? I mean, I'm like, okay, really? You're cleaning up. My dog had a seizure when he was here, and she started having I can't think of a bowel movement. Immediately, he's in there cleaning up her butt. I mean, her bottom, cleaned her chest. I mean, who does that? Cleaned up the poop because I was about to go in the backyard to clean the poop up. We're dating, so we've been dating for like 5 months. So and he came out and did it for me. He did the dishes. I'm like, what the? Who are you? Who knows? So good people. Drew, you have the baby, right? Is that you? Someone has a baby. Yeah. Okay. Where's the baby? I never hear noise.
He's not at the house right now, but I normally come to class. I go to the cafe around the corner because otherwise he will be screaming.
I'm like, are you sedating the baby? What are you giving the baby?
I've been thinking about it, honestly. No.
I may have given a Benadryl or 2 to my dogs. So
we discussed it.
you know what? I can't even imagine. Oh my God. Okay, I salute all of you who have children. Thank you for asking. It was good. I think it's going to be good tonight. I'm getting tired. The only thing is I'm so tired. But we'll see. Hopefully I'll get through the meal. And I appreciate you asking. And next week is that veterans. Do we have class next week, you guys?
No.
We don't?
On Thursday, no, but Friday, I think so.
Right? Because it's the opposite admission. Weird, right?
I just know I saw on your assignments something like no class or something like that.
I think you're right. Because I asked Colleen or something. So if it says whatever it says, follow that. But I'm not 100% sure. They used to give infants alcohol. Yeah, on their gums. You're right. But be careful because God forbid, like you give too much and then God, something could go wrong. Alcohol is always the answer. Oh, Max. So I'm not going to give you any advice on that just because, but I do know how much is enough, but I won't just in case because safety. And on Shameless, they talk about, or no, Modern Family, they talk, and so Shameless too, they give Valium on the baby's lip. If you guys watch that, it's the best show ever. The new season's out if you haven't watched it. So, all right, my almost called you my loves, but because that's what I call my clinical groups, my fabulous class. We're gonna end it here. I will post up this video when it's downloaded. I'll do everything I said I was gonna do. I'll open the quiz right now, and let me know if you have any questions, text or whatnot, and I will double check about next week just to make sure because I don't want to. if anything, maybe I'll do a video or something, because that might be nice for you to have a 3. Do you guys have med search next Friday? Even if you do, it's okay. Maybe I'll just do a video. I mean,
now I don't know if we have med search or not.
Because next week is more review. I'm doing NCLEX questions. So the only reason I wasn't going to do a video is if you had questions, but next week we're literally doing like 15 you do. So I was thinking just making a video, 15 questions, go over them, and then medication review on specific medications on depression, anxiety, bipolar, everything we've already gone over, and then just posting that, because technically it is Veterans Day. So we could do that too, but you need to watch it because it's going to be on your test. But I don't know how to do this with 60 people. We can't vote. So, and I don't want 60 text messages. So we'll keep in touch. If anyone has very, 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 very strong feelings like they want to do it in class, because this is a video, this is one we could do on a video and it makes sense. If anyone has really, really strong feelings, email me. If I don't get more than 5, then I'll make it a video and I'll let you know in full time ahead. Okay. And again, I will not put your final on the same day as another final, and you will have 24 hours to do it. So you have, hopefully that took some stress off of you. All right. All right. I'm only 1 minute over of what I said I was going to do. So I hope you all have a wonderful evening, and I'll open the quiz now.
Thank you.
Thank you.
Have a great rest of the
Bye.
day.
Have a great day.
I will. Thank you guys so much.
Hey Amanda, I had a quick question actually about lithium.
Yeah, please.
Yeah, I'm not trying to take you away from opening up the quiz for everybody.
No, you're fine. Go ahead.
Okay. Yeah. So there was a podcast I was listening to a while ago. It was about lithium and specifically kind of like what it does to the body and everything. And I was just curious if you've heard anything about what they were talking about lithium specifically was that one of the reasons why they like using lithium is because it acts similarly to sodium in the synapse, but it's at a slower rate.
Yes.
So that's what causes the dulling effect. Does that sound at all right?
That's what I have been so we have I forget what they're called. They're like staff meetings about patients. And it's interesting that you brought that up, because this was like 2 weeks ago. They were talking about that, something very similar. So one of the doctors had mentioned it. So I don't know if they had the same listen to that or whatnot, but there is evidence to support that. I don't know if it's evidence-based yet, but there is evidence to support it, and they're looking more into it. Just as the woman said, they're still really not sure, like exactly 100% how it works, but they're getting more of an idea. But that makes sense, right? Everything that we just learned, that would make sense.
Yeah, that's like going through, like doing this bipolar and learning about lithium is kind of like it was kind of tying it together. And so I just wanted to see if you've heard anything similarly to that one.
I have. And I personally, in my personal opinion with the education that I have, I think that's why.
Okay.
Yeah.
Well, that does make sense. Yeah, it was definitely one of those interesting, it was a radio lab, and I just kind of put it on for a little bit, and they were talking about lithium and bipolar disorder. And they just started going into the table of elements and they were getting it was very, very chemistry based, and they were discussing the elements, but it was cool how they discussed lithium and how it can replicate or mimic sodium.
Yes, exactly. That's exactly right. And it's actually funny enough, it's on my list of now would be 257 things to do. So it's a little bit at the bottom, but was research this. So hopefully I get around to it. But now that you just told me that, it makes me feel better, because I'm like, this doctor, I don't really know, but it makes complete sense. So I'm glad you said that, and I kept it recording, so it's on the recording.
Oh, great.
Well, so no, hopefully people will see that, and because I think it's really cool. So thank you.
Yeah, regardless, it is fascinating, and I'm really happy that someone else also heard about this.
Yeah, I have. Yep. Awesome.
All right.
Thank you so
Well,
much.
that's all I got. Thank you so much, Amanda. I will see you next week.
I will be here. Bye.
Bye.